some of you coming from very far away to be here for this very special day and occasion, my birthday. I also understand that some of you may be here for the symposium. And as we do not work alone, I would also like to thank the team at CBMS, my adopted Italian home, for the past year, and for them welcoming me into the family. And it is a profound honor to work with Dr. Massimo Fetherston, who in this room needs little to no introduction for his contributions and teaching that are known the world over and deeply respected. Massimo has spent a career trying to convince others that patellar luxation is not a disease, that the grading of patellar luxation is not a disease, rather it's a clinical sign. And so with that, the evolution of the TTT technique was developed to minimize the complications associated with traditional TTT. The evolution of TTTT to TTTT2 involves over a decade and the contributions of many surgeons from around the globe, and many of those deserve mention. I will single out one today who in particular has contributed a great deal, great friend, teacher, innovator, and surgeon, Dr. Trochlear. So today we're going to briefly touch on the rationale for the technique and methodology through a problem-to-solution approach, a little bit about design and technique. We'll cover a little bit of evidence in support of the technique and some resources for surgeons. So, as you've already heard, there are many mentions of the letter T and multiples of the letter T. So it may be prudent to begin with some nomenclature. So the tibial tuberosity transposition, or TTT, is a common technique used in patellar luxation to manage tibial tuberosity transposition in one of two traditional techniques, either a complete or incomplete osteotomy and fixed with either Kirschner wires pinning through the tuberosity and or a tension band wire. So, Dr. Fetherston developed the tibial tuberosity transposition tool and technique, or TTTT, which we can also call 4T, again to address the complications associated with traditional TTT techniques. In this case, TTT provides a method for proximal tibial translation after partial and oblique osteotomy, leaving a robust distal tibial crest without the need for pinning through the tuberosity or cerclage wire. Additionally, it provides a method for the surgeon to be able to translate into a final position, checking patella tracking before final fixation. In the end, a spacer pin is inserted alongside the tuberosity, again, eliminating the need for pinning through the tuberosity or adding cerclage wire. In my hands, the original TTTT tool and technique was a successful technique for my patients to allow for rapid bone healing, early return to function, as well as decreased implant-associated complications. With that said, there are some surgeons that found it technically challenging to place two pins with the original tool, especially in tiny patients. In those patients, it would often require small pins at 1.8 millimeters, which can bend, and so it also limited the size of the patients that we could use this tool and technique for. In 2019, I visited Dr. Fetherston, and he showed me this prototype for the next version, which went on to become TTTT2. And Massimo is a busy clinical researcher, author, teacher, and surgeon. Well, he's a busy guy. And so it was no surprise when I showed up a few years later to work alongside him that this prototype was still in the workshop where many of his ideas come to life. So I made it a little bit of a mission to encourage and push forward with this tool because I feel so strongly that the methodology behind the tool and the tool itself is such a valuable contribution for our patients again, to decrease complications associated with this common procedure and improve outcomes. This video is here, and we're going to return to this point several times to point out that this technique is based on slow bone bending of viscoelastic bone. And so, in many times I hear people say, no, I've used this technique, however, I don't use the jig, and I use a pin or an osteotome or some instrument to simply move the tuberosity and translate it. I would argue that you're not doing this technique correctly, that if there is a robust distal tibial crest, as should be planned, it is not possible to do this at the correct speed without the tool. So we move on to what is the tibial tuberosity transposition tool and technique 2, TTTT2 or 4T tool. What happened? Not sure. Imagine the Star Wars theme. You can all hear it in your head. I know that you can. So, better with music. So, perhaps we can move on to P4T2, and I would like to introduce P4T2, starring R2D2 as P4T2, starring Dr. Massimo Pettizoni as Obi-Wan Kenobi, and in supporting roles, Scott Fetherston as C-3PO, and Dr. Trochlear as Luke Skywalker. Here we go. Thank you. So if we take a problem and solution approach to traditional TTT, we see that in the literature, reported complication rates are relatively high. Some of those contributing factors to that are that accurate assessment and surgical planning are absolutely foundational to success. And if these are ignored, it may contribute to high complication rates. Additionally, when a tibial tuberosity transposition traditionally is performed to compensate for femoral deformities or performed in a tibia to address torsion in cases where a proximal tibial osteotomy would be more appropriate in cases with tibial torsion over 15 or 20 degrees, it can also contribute to this high complication rate. These video illustrations illustrate a couple important points. The video on the left is obviously a CT axial view of a tibia with 22 degrees of external tibial torsion that was contributing to medial patellar luxation. And there are a couple of important points. One is the tibial plateau has a pink line, and as you see, this illustration represents a derotational osteotomy, similar to a proximal tibial osteotomy. And so in correcting the deformity, the tibial plateau is moving with the tuberosity. In the illustration on the right, we have the same tibia, the same view, 22 degrees of torsion. And what I've done is simulated a tibial tuberosity transposition. And a couple important points. One is that in a tibia with this degree of external tibial rotation, it's simply not possible to translate adequately the tuberosity and apply appropriate fixation. And even more critically, if you see the line at the back of the tibial plateau, move this over here, you see that the tibial plateau has been left behind in the plane of the deformity and will now be working in an oblique fashion for its residual life. This points out sort of the treatment algorithm where TTTT is appropriate. I don't believe we have that final number, but I would argue that somewhere in the 15 to 20 degree torsion range is where we would apply this tool. So additional problems associated with traditional TTT are that minor complications are frequent, and discomfort arising from the superficial presence of the pins and wires not only, it's not uncommon, but it can lead to persistent lameness and implant removal following bone union. Additional problems include surgical complications, simply suboptimal osteotomy and or implant placement. The more caudodistally the pins are directed from the entry point, the higher the risk of avulsion. Tibial tuberosity avulsion is reported to be much higher in cases with one pin rather than two pins, and it's been demonstrated that the addition of a cerclage wire as a tibial, tension band wire, decreases the risk of avulsion. The traditional TTT technique also does not allow the surgeon to verify patellar tracking prior to final fixation. And to date, there hasn't been a method to be able to accurately measure and estimate the amount of translation required for this technique. And so, looking for solutions, Massimo set out to find a surgical technique and a tool that would meet these criteria. If we develop a technique and a tool that would make it possible to complete an incomplete tibial crest osteotomy that left a robust distal attachment to resist the pull of the quadriceps mechanism, would it be possible to provide a method for the gradual proximal tibial translation of an incomplete osteotomy to allow for slow bone adaptation? He wanted to find a surgical technique and tool that allowed the surgeon to assess the patellar tracking prior to final implant placement, as well as a technique that would allow for no pins to be placed through the tuberosity, no tension band wire, and in the case of the TTTT2, P4T2, a tool that would overcome some of the early limitations of the original tool that I already spoke about regarding the size and the complexity of placing pins in small patients. And so what was born is TTTT2. This video animation will give you an idea of the technique as well as how the tool is applied. Better with sound, it wasn't working. We've also taken the liberty to slow this down for those of you. This obviously was fast. We don't complete the surgery within 1 minute, but I hope it gives you at least an outline of how this tool works, and now we'll go into some details. So most importantly, what is new is the tool to streamline the surgical procedure. What is the same is the methodology and the principles behind it. So those of you familiar with the original TTTT, we're using the same methodology of an incomplete and oblique osteotomy. The tool is simply applied in a different fashion. There are some mechanical considerations behind the design of this technique. Essentially, the geometry of a bone greatly influences the mechanical behavior, such that shifting the osteotomy plane caudally allows us to retain a larger bony attachment. Additionally, the cross-sectional area of the bone increases, resulting in higher tensile and flexural strength. Also critical is that the stress and strain on bone behavior is affected by the bending rate. And so the quicker the bending, the more the bone weakens. Thus the importance of following carefully the technique and this set speed has been designed very carefully to allow for the viscoelastic bone to bend and adapt without going past a breaking point. In support of this is a paper that's recently been submitted and was presented at this year's VOS by Anna Sullivan and with Selena Tinga's group, a cadaveric study evaluating a biomechanical comparison of the spacer pin or 4T technique to two established methods of stabilization for traditional TTT, both in incomplete osteotomy, stabilized respectively with pin and tension band and 2 pins through the tuberosity. And most importantly, the mechanical properties of the spacer pin technique, the TTTT, were no different from the tension band wire or 2-pin techniques. And while not statistically significant, the 4T technique demonstrated the greatest ultimate failure force over all techniques. The tool and technique has been described, but has not been widely reported in the literature. Recently, Eloy Grucci published a paper in 23, essentially a case series with 5 dogs using the technique of TTT in combination with DFO in the successful treatment of medial patellar luxation. A paper that will be presented as a podium abstract at this year's ACBS and recently submitted for publication out of Dr. Pezzozzoni's group evaluated a retrospective case series with 42 stifles utilizing the TTT technique. And the important conclusion is that the 4T technique was appropriate for tibial tuberosity transposition in the clinical management of dogs with medial patellar luxation in grades 1 and 2. It demonstrated lower complications and lower recurrence rates than traditional TTT. 1 out of 42 had a recurrence and was treated with a trochleoplasty not performed at the time of surgery and went on to excellent clinical results. All 42 had complete osteotomy healing at the 8-week mark, and there were no implant-associated complications reported. So what is needed for this technique? To begin, we have a book that's new and will be available with a QR code and some information coming from Intrauma. But to begin with, it's important to, again, accurately assess and plan for deformities, and that begins either with a well-described CT technique or estimation from tibial radiographs to estimate the degree of torsion. And then what's new, and you'll find in the book, is a geometric and trigonometric method to plan the amount of translation required. And again, the new tool follows the same principles as the original. The tool itself is composed of 4 parts, has a body with a slot for the blade here, threaded hole for the pushing bolt here, and this we call the pushing bolt, non-threaded hole for a threaded pin, the small threaded hole for a set screw to lock the pin, and then a larger threaded hole to be able to lock a set screw to the blade. The tool is available in 4 sizes to treat micro, mini, medium, large, and giant breeds, and will be available as individual tools or as a complete set in this well-designed case that allows for easy recognition when things are put back properly, and an empty space to be able to place pins that are required in drill bits for the procedure. With that, this is a QR code that if you scan, you'll be taken to a link, and when you click on TTTT2, at the appropriate time in the future, Intrauma will be able to send you information regarding upcoming courses and access to these other materials that I've mentioned. Additionally, I'll just highlight that we do have a somewhat active group online on Facebook of users with the TTTT technique and now 4T2 that has some great discussion and learning possibilities.